Good afternoon, folks, or good morning, good afternoon, good evening, wherever you are. I'm Shaili Prasad. I'm the Executive Director for the Center for Global Health and Social Responsibility at the University of Minnesota. I want to thank you all for joining us for this event. This event is to celebrate Global Health Day. Global Health Day this year was on April 7th, earlier this week. And today we are excited to have this panel to discuss a very important topic, addressing stigma in global health, an ethical approach to research. But before we get started, I just want to give you a little overview of our center and what we do. The Center for Global Health and Social Responsibility was formed in 2010, and our mission from the outset has been twofold. We want to advance global health education, research, and training, and we also want to promote sound and socially responsible global health engagements. Our center is a member of the broader University of Minnesota ecosystem focused on advancing not only global health research and education, but also global health ethics. And that mission is going to be front and center in our conversation today. But first, a quick commercial break. Before we get started, I want to talk a little bit about a few opportunities at our Center for University of Minnesota students and faculty. We just opened applications for our fall Global Health in Local Context course, which will run from September through December of 2025. It's open to, obviously, University of Minnesota's graduate students, faculty, staff, and also community members. It's a very interesting course because the course is conducted both on campus and in various settings around town. Applications are also open for our Global Health Ethics course. It's a one-week immersive course that runs with the Public Health Institute and examines the current approaches to global health ethics. We are also currently accepting proposals for a Global Health Seed Grant program. This is for University of Minnesota faculty interested in starting with some particular research projects around the world. And finally, we have our Global Health Ethics and Practice Awards that is open to University of Minnesota graduate and professional students. And up to $2,000 is given on this award for engaging in internships, applied experiences, research fieldwork, and other hands-on practice abroad. I know I went through this real fast. I would encourage you folks to visit our website to look at all of these opportunities for you to apply to. Before we start this discussion, I want to inform you folks that we have a Q&A function. So if you have any questions during the presentation, please put in your question in the Q&A section, and I will post this to the panelists. Today, we're going to be talking about stigma in global health research. Global health is a complicated subject as it requires researchers to take into consideration various cultural and community beliefs. And what might be frowned in one place might be accepted in another. And it's imperative for global health researchers to get to know the communities and try to understand how to make the research more impactful. Ultimately, it's the balancing act of all of this that brings the charm out of global health. And today we have three excellent panelists, who have experience in global health research and can speak to this complicated issue. So it's my privilege to introduce today's panelist. We have Dr. Nadia Sam-Agudu. Dr. Sam-Agudu is a clinician scientist in pediatric infectious diseases, implementation science, and global health. She splits her time between the US and Nigeria. She's a professor of pediatrics and the director of the Global Pediatrics program at the University of Minnesota Medical School. She also serves as a senior technical advisor for pediatric and adolescent HIV and is a senior fellow at the Institute for Human Virology in Nigeria. Her research is focused on the application of implementation science methods in the prevention and treatment of HIV and other major infectious diseases affecting children in African countries. She also provides her expertise in collaborations and networks for implementation science training and capacity building in the US, in Nigeria, and various other African countries. Dr. Sam-Agudu is a member of the Nigeria Implementation Science Alliance, NISA, and leads the Central and West Africa Implementation Science Alliance, CAWISA. Dr. Sam-Agudu, welcome.
Thank you.
Next, we have Dr. Kathryn Cullen. Dr. Cullen is a tenured professor in the Department of Psychiatry and Behavioral Sciences and the director of the Division of Child and Adolescent Mental Health. Her research examines the neurodevelopmental underpinnings of depression, self-injury, and suicide risk in adolescents and young adults. She has also done work in testing the efficacy and mechanisms of novel interventions, including neuromodulation, pharmacology, probing oxidative stress and glutamate systems, and this particular part, which is really exciting for me, the use of creative arts-based approaches in promoting recovery and thriving amongst youth. Her areas of expertise include depression and non-suicidal self-injury, child and adolescent suicide, bipolar disorder, borderline personality disorder, and obsessive compulsive disorder. Dr. Cullen, welcome.
Thank you.
Our third panelist is Dr. Kumi Smith. Dr. Kumi Smith is an associate professor in the School of Public Health's Division of Epidemiology and Community Health here at the University of Minnesota. She studies issues at the intersection of infectious diseases, substance abuse, and unstable housing. She has also developed structural intervention to better support clinical workers in providing culturally specific and trauma-informed care for marginalized patients. Much of her international work is based in China, where she has lived and worked for several years. Dr. Smith's area of expertise includes HIV, sexually transmitted infections, infectious disease dynamics, intervention science and sexual health, and healthcare stigma. Thank you all for joining us today. To get things started, I'd like to ask each of our panelists about their experience with stigma and global health work. And in addition, maybe we should begin by defining what stigma is and what it looks like in the work that they do. So Dr. Smith, I'm going to start with you. How has stigma presented itself in your work, and what does that look like?
Thanks, Shaili. Yeah, I can speak about how stigma is manifested in my work as a HIV epidemiologist. And I was born the year that the first MMWR came out, so I'm as old as HIV, or as old as our kind of modern epidemic as we know it. And I know that because of that, throughout this lifetime of our study of HIV, it's turned from this deadly disease into something that looks more like a chronic disease. And over that time, epidemiologists and other health researchers have used these models from chronic disease management to deal with HIV, which is to talk about care cascades or treatment cascades. And so it means, it gives us a spectrum on which to observe from HIV testing to getting onto treatment to having that treatment suppress your viral load. It gives us a set of goals that we should be targeting all along that kind of lifespan. And yet, though, people who look at stigma will use that same spectrum to point out how stigma interferes with literally every single process on that spectrum, whether that's making it really difficult or challenging for people to get HIV testing for fear of being called out, making it very hard for people to seek treatment. And then once they're in treatment, a suboptimal care or mistreatment by healthcare providers can make it hard for people to achieve their treatment goals. And it might even sort of end up sort of driving them away from care. So we're at this really amazing point with HIV and a lot of other infectious diseases where we have these really effective biomedical interventions, like PrEP, effective treatment, rapid tests, all kinds of things. But we're really failing to kind of get them into the hands of people who really need them. And we're really under our targets. And many folks have pointed out the important and central role that stigma plays in that by kind of being this barrier that people just can't seem to get across in terms of access to these tools. So that's the ways that HIV stigma has really shown up in my work all across these kinds of different health spectrums. So yeah.
Thank you, Dr. Smith. Dr. Sam-Agudu, what about you? How has stigma presented in your work?
So I also conduct HIV research, but particularly in children and young people. So that brings another dimension of stigma, especially among adolescents. My research also includes young men who have sex with men, and then also looking at sexual and reproductive health among adolescents. That includes teen pregnancy. And my research also covers Mpox or monkeypox virus infection. And so all of these conditions among these different populations really sort of combine to cause very high stigma situations. And for me, I look at stigma as the negative beliefs and attitudes of people with respect to the others who are affected by these infectious diseases and who are also members of key or minority or ostracized populations. So discrimination then is the negative actions that are taken and that affect these folks as a result of the beliefs and attitudes that people have, the negative beliefs and attitudes. So how I've seen stigma is really looking at where is it coming from. I've seen stigma against different populations that I work with coming from their own family members. Given that I deal with children, I've seen stigma from school teachers, from healthcare workers, as a healthcare worker myself, and researchers, even sexual and romantic partners of people living with HIV or who have mpox, and imagine situations where like a child is shunned in school or in the community, or a child is given a specific set of like a plate or utensils or cups to use because that child is living with HIV in their own household. And so once you start dealing with people who have been affected by stigma like this, and you're trying to conduct research or provide care for them, you have to deal with a significant mental health issue, not only because they may have, depression or other diagnosable mental health disorders, but due to stigma itself. And so these are the things that we have to think about when we conduct research on any topic among people who are affected by these highly stigmatizing conditions. Thank you.
Thank you. Thank you for that. And I think that's a perfect segue for us to ask about the mental health spillover effect from other diseases. But Dr. Cullen, both for that and for the work you do, what are the stigma? How does stigma present itself?
Yes, thank you. Yes, even though I'm studying a different disease area, it's very similar concepts to negative beliefs and attitudes about a problem that is scary and not well understood. And mental health problems have been stigmatized for a long time, as long as we can remember, and are stigmatized across cultures. Some cultures more than others, some communities more than others. And I am also am focusing on young people. And interestingly, we tend to find that young people are a little bit more open about speaking, just communicating and talking about their mental health. Not always, but young people are a part of a community, and so these are so just like Dr. Smith was saying, the stigma it serves as a barrier to care. It's one of the major barriers to we have other barriers to accessing care and mental health, but it's one of the main barriers. Because people might, because of their own attitudes or beliefs about mental health, or because of what they perceive, they might be discriminated against, receive discrimination from others if they knew about their mental health problems, choose not to pursue care, and that's that can lead to worse outcomes. And so that's one of the some of the ways that it presents in my research.
Thank you for that. The three of you have worked in various contexts, both within the US and in other settings around the world. And one of the questions that comes up quite often is like, how do you become not too ethnocentric and be possibly a little dispassionate from the work that's happening, right? And I'm asking this question because these are emotionally charged issues. Stigma tends to be an emotionally charged issue. And the fields that you folks are working in are highly emotionally charged. So how do you balance the two of being the dispassionate researcher versus trying to change premise of stigma? Do you do that? Or is that not the role that you play? And I'm going to ask Dr. Cullen this question first.
I think that if I understand the question right, and hopefully I'm using the right terms, I think we have a role. part of what we are offering in this research is discovery and education. And I believe that through increasing knowledge among a community, among, around the world, within a person, within a community, these are all ways to decrease stigma, because it decreases fear. If we can have conversations, understand what's a real fear, what's not, really like demystify things and address myths and things like that. It can help a lot, and sometimes it doesn't take much. It sometimes takes a lot, but sometimes it doesn't. It takes less than what you think it's going to take to really make a big difference. So I see that as some of the role. Is that kind of what you're asking?
Yeah, yeah.
Okay.
Does the role, from the dispassionate observer move to a part of decreasing stigma, right? So, yeah.
Yeah.
Kumi, what about you?
That's such a great question, Shaili. I think in some ways it's important to lean into the emotions of what you're hearing. Even just reading a paper of interviews with, say, HIV patients or any other kind of group that's really marginalized, it can be really painful. And I think it's important to acknowledge just how much suffering there is, that's so undeserved. And that's often coming from the very people who are supposed to be helping you. The idea that you go to a doctor and say, please help me, I'm sick, and to have them mistreat you is really hard to read, and it's really hard to absorb. I've also done these interviews, and it's painful to hear. So I think allowing that human part of you to kind of experience those emotions and to empathize with people and to go through with that are really important to keep our humanity and to make sure we stay oriented towards the right North Star. But in my research, I actually do work with the folks that we might, like in stigma research, characterize as the so-called enactors of stigma. So these are folks who are, unlike Dr. Sam-Agudu, like are not HIV specialists. They are not exposed to HIV patients. They don't have that training. And so we have to work with these folks to try to help them understand where their weaknesses are. And so that's a place where it is really important not to come as a bleeding heart advocate for the poor and the oppressed, because if we do so, we can risk sort of antagonizing these doctors and putting them in a position that suggests that they somehow don't care about their patients, or they don't work hard, or that they're not kind humans. And so that by being dispassionate in that way, we've been able to uncover that a lot of the stigma that they might inadvertently enact doesn't come from a bad place. It often comes from ignorance or fear or anxiety or lack of training, things like that. So I think maybe compartmentalization is what I'm talking about, can be sometimes really important. Yeah.
Yeah, it's an interesting point you bring up. It's almost like asking, what is the root of that stigma? You can't label the person as bad. It's just that their framework of approaching the topic is different.
Yeah.
And Dr. Sam-Agudu, you've had the experience of working in multiple communities across various parts of West Africa, various parts of the US, including rural areas of the US. So how has that experience informed your research part too?
I think that, when we're talking about being dispassionate, like for me, the way I sort of respond to that immediately is my reason for going into research is not dispassionate at all.
Mm-hmm.
It was extremely passionate. And so that is something that grounds the work that I do and the reason why I do the work that I do. However, and I do both qualitative and quantitative work, right? Working whether in rural areas or urban areas. And the content of the data we collect in these qualitative studies among people living with HIV, some are children or some are adolescents or caregivers, it's really hard. And so most of what I have to do in the collection of the data myself as a facilitator is to be as dispassionate as possible, but still drawing the information that we need and making participants feel comfortable enough to bring that information out. When I analyze data, I'm dispassionate as well. And so, but then the motivation for going into the work and then is passionate. The collection of the data, I try to be dispassionate so that we get all that we need and then and analyze. But then in terms of disseminating and telling people the importance of what we are finding, we sort of re-inject the passion back to make people really get the point of what we're doing. Yeah. Thank you. And that goes for whatever setting I've worked in, whether in the US or in African countries. Yeah.
That's a good point. You should have passion for the work, but dispassionate of how the work is done, right? So that's the balance you have to strike, which I guess is going to be a very difficult one, particularly in the fields that we work in, right? So thank you for that. The next question is more about extending this one step further. You folks have talked about, creating the research in a way to decrease the stigma part, right? The follow-up of that is, what about engaging communities in this process? And what role does that have? What I mean by that is, a lot of times in the research world, there is a tendency for us to be very narrowed in our focus to the particular folks that we are talking to. What about the larger milieu in which they live in? How do you then approach that part? And Dr. Smith, over to you now.
Because I gave a pained face at not knowing how to answer that. No, I mean, it's a really great question. I think, the starting point for us is always actually to have that narrow focus. So we work on stigma experienced by men who have sex with men and people who are living with HIV, and sometimes people who have that both identities. So we've learned that, we can read all the papers we want and learn about the research all we want, but we have to still talk to people in that community to understand what stigma feels like and looks like to them. And it comes down to even as being as specific as, I can't tell if this doctor was weird to me because of my disease status or because of my sexual behaviors, but it's something felt off. Even down to that level of specificity is so important. And so, but in talking to them, we do get hyper-focused on sort of what things matter to them, what types of body language doesn't feel right, what kinds of word choice the doctor uses. All those things, I think, can only be interpreted through the eyes of the people who are experiencing that stigma. I don't think we can use research to stand in and say, no, this is what stigma is in your case. But I think by zeroing in, we're actually learning a lot about, I don't know, I get a lot of questions about what are societal views of homosexuality in China today? Or, how do Chinese healthcare providers feel about HIV these days and all those kinds of things? I can only sort of start to guess at those answers through the stories I'm hearing from our community members. So when you talk about that sort of larger social context, I think if we listen deeply, we're going to start to realize ways in which those do kind of shape what stigma looks and feels like to these groups. It also really helps to connect with fellow researchers like those on this panel to really kind of compare and contrast what, how stigma manifests in different places. It really does vary. And yet, when you do compare, there is kind of this undertone of universal kind of human patterns and behaviors that you can also start to pick out. So holding both is I think an important step. But yeah, that's why this panel is so great.
Thank you for that. Dr. Cullen, your work is slightly different than the HIV area, particularly here. Similar question to you. The role, particularly in a young adolescent, child, the context of the community and what that means.
Yeah, I think it's, in research focusing on children and adolescents, we don't sort of study them. We don't sort of approach them directly. We first go to their parents or their guardians, and they're in a community. And so, especially with global health, when you're going into a new community that isn't where you live, or, there's surprises, oh, our students could never, could not be doing this kind of mental health measure, or things that we think, in my university are, typical standard measures are sort of seem more scary or, risky in maybe another setting. And so it's about, I think first of all, I'm more of a junior global health researcher compared to the panelists, my co-panelists, so I'm learning a lot. But what we've done so far is just try to meet with community leaders, find out what they're afraid of, or what their concerns are, I guess I should say, and see if we can how we can adapt our approach if that's possible, or if it's and still maintain the integrity of our our research and addressing the research question, or maybe we need to update our expectations about what we can do in a first step before we can fully address that research question. So really, investing the time in building relationships and just learning and listening.
Thank you. Dr. Sam-Agudu, over to you.
All right. So for me, my research is heavily founded in implementation science. So to do this without community engagement would be criminal. I'd probably be thrown out of the implementation science group if I did my research without community engagement. We have, multitudes of frameworks for how to do it and do it well. And so for us, yes, that work is extremely important. You're working with people affected by HIV. You have children involved. And what we are doing in implementation science is making sure that whatever needs to be done in terms of implementing interventions that are evidence-based is done and done well. So we are looking way down the line to make sure that not only are we generating evidence, but then it's going to be done. And so we take the long road, right? We're looking long-term. And so that's why we start, continue, and end implementation science projects with community engagement. And many times to a point where we have different levels of community engagement, from simply informing all the way to empowering and power sharing. And so that's a very intentional way that we approach these things, because we know that the best way to get things done, get them done completely and get them done with sustainability, is to make sure that the community, whether it's community of practice or community that is affected or geographical community, is carried along and understands what we're doing and are part of the decision-making approaches. Yeah, thank you.
Nadia, your answer brings up another interesting aside. As you, for example, start a new research project or a new area you're going to, one of the key almost always is to build your team, right? Your research team. And in a significant number of situations, a majority, if not all of your research team is from the local area. What do you do to address the issues around stigma and community approaches in that setting? And I'm going to start with you because you started the discussion.
Yeah.
I'll come to the others.
Absolutely. I'm very, very careful about who I recruit onto my team. One, because you want to get a certain level of, quality or commitment to the cause or whatnot. I think I try to build my team with people who have a little bit of activist in their system, someone who's going to keep going even when there's nothing to work with, right? But then with respect to working with, whether it's children, people living with HIV, young men who have sex with men, young women who might be experiencing teen pregnancy and all that, I really want to make sure that we are working with people who approach their work from a minimum stigma or anti-stigma approach. And so part of what I do when I'm interviewing people, for instance, if I'm doing a study among men who have sex with men, to say, I need people to join this team who are actually okay working with men who have sex with men, who accept them as they are, who work with them to make their health better. There have been instances, not on my team, but of colleagues who have had brought researchers onto their team, where these researchers start sort of admonishing pregnant teens or trying to preach to young men who have sex with men to change their lifestyle and all of that. And we've heard some of this feedback from the young men who have sex with men. And this is not what we are looking for in these studies. So I really make sure that I am screening people who are going to approach the work from an anti-stigma perspective. And if I do have information that they are not doing so, I will need to speak with these people, or when I need to, I actually will fire them, because it's detrimental to the work that we're doing. Thank you.
I like that anti-stigma phraseology itself there. So, Dr. Smith, I know we've talked about developing teams, particularly since a significant amount of your work is in China.
Yeah, I think I do follow sort of a similar logic of you have to have some folks from the community who are already doing this work join you, or rather, maybe you're joining them.
Yeah.
So we're fortunate that in the setting where I work, which is in Guangzhou in southern China, there's a pretty rich sort of nonprofit culture. I mean, as sort of non-government as it can be in China. And there's a long tradition of people who've been using whatever tools they have available to advocate and to educate and to really speak on behalf of the community. So, you know, a lot of projects that I've worked on come out of conversations with those folks, so that when we finally do get funding, we say like it's a go. They really feel a little bit of ownership over the project too. And then luckily for us, like some of their former staff have become our study coordinators. Many of their volunteers actually end up sort of working on our studies. And I think, you know, to Nadia's point, if you can do it well, you're kind of growing that community of people who are, you know, doing this anti-stigma work together. And I love watching how community activists who are like, break the system, become really passionate about measurement error, or, you know, like survey data quality or things, because they realize that this is a really powerful tool. So it's great to see how researchers and community members can really become aligned on projects like this.
There's a science diplomacy in that messaging.
Yeah.
Dr. Cullen, and we've had conversations about this, about looking at mental health from a much more comprehensive viewpoint, not from a purely medical, biomedical lens. And so a lot of the work that you've done incorporates that. So my question to you is twofold. One is, how have you been able to do that? And the second is, are there deliberate ways to do that in a way where the mental health aspect is not as emphasized and the other wraparound services are more emphasized? Or is it a approach you take and see what happens?
So before I answer, is it the case that would you guess that the medical aspect would be less stigmatized?
I'm curious if the medical aspect would be more stigmatized.
Okay. It's a good question. I haven't thought about it in that way. But yes, we do take a very sort of whole person approach. You know, that's our practice here in Minnesota. The work I've been doing in other countries has not been very medical at all. It's more been this creative arts approach, which is like more about well-being and you know, expressing oneself and finding ways to connect and finding ways to navigate through difficulties through kind of authentic self-expression, which is not very medical, but yet I'm a psychiatrist. So yeah, I guess I would say the ways I've been encountering stigma in that context is more just about the idea of even talking about mental health and willingness to, whether or not somebody would be willing to even answer questions about it or something like this.
Yeah.
And I would say, in terms of, I was really interested to hear Kumi and Nadia's comments about and their experiences about how they build teams, because that's very good for me to learn. And when we've, in the small amount of work that we've done in other countries, building teams, we have had some great opportunities to connect with people on the ground. And I've just been learned so far, my main takeaway has been how valuable that is to just get their experience. So generally people who come to, who kind of express an interest in collaborating on a mental health project are not going to be sort of anti-mental health or anti-psychiatry, you know, so I tend to sort of just naturally not have like people that I need to sort of weed out anti-stigma or something like that. But I do find that we learn so much from people in these different communities because their experiences are so different from what I've experienced here in Minnesota.
Right.
And that is a great way to you know, just even without talking to community leaders, just talking to our own collaborators and getting their experiences helps shape our approach.
Wonderful. Thank you. We do have the Q&A box open. We already have a few questions that are populating that. I would encourage folks to ask questions through the Q&A section. And I'm going to get us rolling with that. And the first one, Dr. Sam-Agudu, how do you balance respecting community health priorities with choosing health issues that address their deeply rooted stigmas?
I get that a lot in terms of that experience. For instance, what I do is I show them the data. You don't want to deal with HIV or you don't want to deal with teen pregnancy. Well, here is the information on the prevalence of HIV or of teen pregnancy in your community. And so why don't we have a conversation about how to address this? And so then starts the long journey of sort of working with people to come to it. But you show them the numbers, right? You show them the numbers. So that's like one of the surest ways to try and prove that it is a problem and we need to address it.
Yeah. You know, it's interesting always, isn't it? This is one of the underpinnings of a lot of the global health challenges is whose agenda is it? Is it the researcher's agenda? Is it the community's agenda? But then the premise almost always is like, how do you then recognize that it is an issue? It may not be the agenda, but it's an issue. So your point is a good one, showing them the data, showing them the information, and also probably from a research perspective, showing why it is important, right?
Yes, and so to add to that, the why is, you know, we have data, but then we'll go into the community like with an implementation science approach and do formative research, do a few interviews among some selected groups and say, is this a problem at all? You know, and why is it a problem? Why is it not a problem? And then get some more. I love qualitative information for someone who was trained very quantitatively, and it really helps you to understand what's going on.
Yeah, thank you. Dr. Kumi Smith, there is a question that we probably have answered bits and pieces, but this anonymous attendee has a very elegant way of putting questions that I had already asked. So I'm going to ask it anyway. Regarding the fear of perceived discrimination and stigma, when should a researcher acknowledge the validity of such fears versus trying to dispel them? Secondly, how does your work address the root causes of stigma outside the individual? And finally, how do you navigate tension between cultural sensitivity of engaging stigmatized individuals and the cultural humility that may be violated by battling a societally held stigma?
Yeah, those are three really good questions. I think I can start by working backwards about how we as researchers and often as, you know, foreign researchers can come into a place and announce to the community, like, this is unacceptable behavior, you cannot treat people this way, and we're here to tell you otherwise. That can be a really problematic approach that can backfire and fracture alliances that are already, you know, existent there. So I think that's a super important thing to consider. Global health is, in many ways, it does have sometimes a missionary zeal. You know, we do have beliefs about appropriate family size or appropriate ages at which to have children, or what kind of sexual behaviors you should have. And we should be wary about coming into, you know, places not our own and essentially preaching these types of things. And so that's where I've kind of found that for us, what has been so valuable is to, much like Nadia was saying, find local activists who are already working on this and get on their bandwagon. And so to that end, it's really been helpful to, as a researcher, I try not to necessarily identify with a particular outcome or a specific, you know, disease or anything like that, and rather to kind of pick some methods and approaches that you find work across a large area of fields. Then if you have some curiosity, just like Nadia says, as you meet people and you start to just talk to them, you'll immediately find a lot of areas for like collaboration. And trust me, no matter what area of health we're in, I think stigma is always going to be sort of a ripe area. I would just add to, with the second question was about the root causes of stigma outside the individual. We've been really learning to take a sort of systems level approach to think about stigma. And this comes from a fellow sort of China stigma researcher who figured out by interviewing doctors that one of the biggest predictors of them sort of scoring poorly on a stigma scale was to realize that it was more common in doctors who worked at hospitals that didn't provide post-exposure prophylaxis, that didn't provide gloves, that didn't provide, you know, other kinds of medical equipment. So what we realized was often driving these behaviors was a feeling that if they had some sort of occupational exposure or other kind of problem, their clinic or their sort of employer didn't have their back. And that's when we realized this is bigger than the individual. It's not just about changing hearts and minds. It's about sort of reshaping entire medical cultures. And that's going to take time. And that's something that I think research can bring some attention to. So thinking at different levels and the ways at which those all kind of shape that, you know, ultimate individual encounter has really been helpful for us. And I'll stop there.
Thank you. Thank you for that. The next question, Dr. Cullen, and this is coming from I wonder if it's the same anonymous attendee. It's wonderful questions coming this way. Such an amazing group. Thank you. Given all the complexities and challenges you faced, what is the one thing you do to maintain your resilience to continue your research? So it's not I'm talking about resilience in the community or the folks you're researching. In you, what do you do?
That's a great question. And I am very curious to hear what Nadia and Kumi have, but it's a question that we all have to address as human beings. We all have to figure this out, and these are very challenging times. And so, and you know, especially for, well, I'll just stop there. I try to organize my work around what I think is most important and try to prioritize what will be kind of the most impact, highest impact for helping the issues, the mental health issues that I see as most urgent. And I also try to find ways to protect my mental health while doing it. And so I'm actually personally a very huge stickler for making sure that I have really good self-care in terms of well-being. Like I make sure I have good natural light. So I asked Nadia, I don't think too much natural light is a thing at the beginning of the meeting. I like to make sure that I get as much, you know, a regular sleep and exercise. These basic things. I really try to do those things to protect my mental health, and I also need to make sure that I'm connecting with other people, other researchers like you guys, other people on my team. I think those are maybe one of the most important aspects of maintaining resilience through difficult times.
Thank you. Kumi or Nadia, anything to add to that?
Go ahead, Nadia.
All right. So for me, I drink a lot of coffee. A lot of coffee, probably too much. That helps me. But I would say on a more serious note, you know, given what drives why I went into medicine and why I do my research, as long as there's a human being in the category of child on this planet, I will be motivated to do my work. And so for me, as long as there are children that I can perceive need my help, whose health could be better, and who I'm trained to care for or to do research for, I will be focused. You know, yes, I have the ups and downs, but all in all, I haven't had anything dissuade me from doing my work completely yet. Not at all. So,
Yeah.
and when you find like-minded people, you are even more empowered to do that. So that's where I sort of get my resilience.
Wonderful. Kumi?
That's awesome. I think for me, a key like breakthrough for me was like this kind of goes back to the US context, but like during George Floyd, I think a lot of us were at home and desperate to try to do something. And often like the only place we could turn to was imbibing too much social media, too much, other people's opinions and things. And I became like really overwhelmed and racked with guilt. And I thought like a lot of my activities were really motivated by guilt about my privilege, guilt about what I couldn't do. Until I heard someone say once that a lot of privileged guilt is probably just someone who hasn't taken the time to grieve. And I thought that was such a really profound thing. And I was like, oh, so it is okay to feel really, really, really sad and to let yourself feel those things. And that if you don't do that, you kind of come at your work with some weird sort of like personal stuff that you haven't worked out. And I think that's why sometimes people can burn out because they don't really know where their boundaries are.
Yeah.
Also, communities can sense that. They can sense when you're there for your own reasons rather than really to kind of be in true service and in real partnership. So I think those things kind of gave me some perspective that you don't need to have a story of trauma, or you don't need to have some kind of really like gripping reason for being, serving and for helping. It's great that you want to do that. But, I think kind of working out those things helps you kind of, stay a little bit more centered in this work. But on a more positive thing too, I think it's just also like working with these teams, like it's really nice to be able to find moments of like joy and like lightheartedness. And just as an example, our team has done these clinic visits where like we have like secret shopper patients go and visit doctors who've consented, but we hope that they have forgotten all about us by the time we show up. But we ended up going to clinics all over Guangzhou, and it's a big city. But when you get to the outskirts, you are going to some really remote clinics. And at some point, I remember our study coordinator had to ride a boat with, the actor patient out to some remote island, and they said it felt like going way back in time. And when they had to pay the boat fare, cash is like not really a thing in China anymore. Everyone just pays with their phones. So they actually got like stranded on the island because they didn't have cash to pay the boat guy to get back to land. And like, so here you are just trying to study stigma. And instead we're like laughing about our study team getting stranded because they didn't have cash, So I felt like moments like those were like, we're all people. We're just trying to do something really like important and really cool. And it's okay and it's fun to like laugh and have fun as part of that. So I don't know. I think those are moments that I think like if we acknowledge those and like have some gratitude towards them, it can like make the whole context of this work a lot better.
Thank you, Kumi. Appreciate that. Next one is a very important question. What advice do you have for early career researchers interested in this kind of work who want to ensure that enter communities respectfully and effectively, but are worried about accidental mistakes?
I'll bite.
Yes.
I think first you should interrogate why you want to go into this type of field that deals with health conditions that are highly stigmatized to start with. So interrogate that very well, understand why you want to do it, and your ultimate goals, right? Your personal goals, and then the goals for the research you're trying to do in general. And then aside that, do not do any of this work by yourself. Especially when you are starting out, you will make such catastrophic mistakes. Work with other people who've been doing this for a while. Usually when I'm going to enter a community to start with, we have gatekeepers that we work with. We do pre-entry meetings before we do entry meeting 1, entry meeting 2, and before we start the study. So there are stepwise ways of doing this that if you're going to do any of this work, do not, just sort of go at it without planning, thoughtfulness, and working with senior people, as well as people from the community. It doesn't matter if you hail from that area. For instance, I'm from Ghana and I've worked in Nigeria for many years. But there are communities in which I go in that I won't just walk in. I will still get people who are living there and who have been living there to recent to do this kind of work. So that's kind of the advice I would give. Yeah.
Thank you. Other thoughts?
I was going to comment a little bit on the early career aspect of that, because I think it's so wonderful to kind of already be so focused at an early career that you already know like stigma is something you want to study. So like props to you. And then I would say the other thing is that it does take a long time, and it's okay that it's going to take a while. Like, Nadia can talk about like contacting the leadership and calling up all the people she needs to, and knowing all these connections that she needs to like work to make it happen. If you're just starting out, you don't have those to go on, and that's okay, and you shouldn't feel guilty about it. For me, when I think about the relationships that I now utilize today, I built them like starting 10 years ago. It took a long time. And I'm not from China. In fact, I'm half Japanese, so that's like an extra barrier sometimes to like work through. But what won me over to the way people started trusting me was that I spent time there. I like lived in Guangzhou on site for a year. I went to the office every day, and working together really matters, but also like sharing stories of what you did over the weekend, or going shopping after work at the market, or things like that become these bonding experiences that really can't replace all of the research that you could do, all of the paper writing that you could do. I think really spending some time on the ground goes a long, long way in sort of building up those trusts and community relationships that will eventually really will pay off. So I think, aligning yourself with projects that are meaningful, getting to know really big name researchers like the two on this call, those are great moves. But whenever you can, try to be in the community that you want to work in. Show your face, show up, and sort of be curious and ready to learn. I think that's gone a long way for many of us.
Thank you. Katie, anything to add to that?
I'll just add, whoever asked this question, the fact that you asked the question is a good sign. Look, you're already doing the right thing, which is just seeking guidance from, potential mentors who, could give you a way to build these relationships. But the other thing is it's not possible to avoid mistakes as a human being. So we're always going to have some mistakes that occur. And what we can do is just be planful and, do the best we can and make sure that we are prioritizing, building trust and finding ways to move forward.
Yeah. Now, this last question is an interesting one. Have you got resistance from funders or institutions or even collaborators about the nature of your research? And how do you address the resistance? I think I would want to say that sometimes it's not resistance, there is lack of funding. The joke almost always is that, it's easier to study children's cancer because there's a lot of funding versus chlamydia, where there's not much funding, right? So, so have you folks felt the resistance part?
I felt the resistance because a lot of my work is trying to work with the so-called enactors of stigma, and coming into these clinic spaces and saying, hey guys, like you should stigmatize less is not a successful approach. So, learning how to, I wouldn't say that we've therefore encountered resistance, but we've therefore really had to consider our strategy and think about how projects like this, how efforts to address stigma, how they come off to the people who are, sometimes perceived as the ones who are the problem. So I think that's an important point to kind of think about where those gatekeepers are, where there's potential sort of stickiness in the process. It's in a lot of unexpected places, I think.
Thank you for that. Nadia or Katie, anything to add to that? Resistance from funders?
Go ahead, Katie.
I have less experience in this. I would say I've I think we have this amazing institute at the University of Minnesota that has seed grants to support global health research and to get us going, but ultimately the goal is to then move on and get federal funding. And the federal funding landscape is changing massively right now. And so I think we all need to learn what our best next steps are and be flexible and be patient. I spent a lot of time in the past year or two learning what the priorities are for NIH, NIMH, for global health research. And these things are, these priorities really are going to shape what kinds of grants we write, and they're also kind of in flux at the moment. So that's just where my mind is. I don't know if it's a helpful answer, but
it's almost like saying this is a time of flux. Maybe we wait and see what the future is too, right? So yeah. Nadia, anything to add to that?
Yeah, I think some of the clear signs of resistance is when you lose your grants because you're working with men who have sex with men, young men who have sex with men. And so, yes, I have had that most recently. And then the other thing that I've had to grapple with is resistance in terms of adolescents independently consenting for research. Most West African countries look at 18 and above. There are Southern African countries that have 13 or 15 or 16, and we are still grappling with 18. So usually I'm arguing with IRB people. I've argued with quite a few people and entities. And trying to tell them that this is not going to fly, especially when I'm trying to do research on sexuality or STIs or HIV among these adolescents, so we need to, this is some of the work that I want to continue, that trying to lower the age of consent for participation in research and elevate the age of consent for child marriage, which is terribly low in those countries. So we need to switch those up a bit. So that would be the resistance, right? The populations you're working with. And then for me as a pediatrician working with children and adolescents, getting the age of consent so that children can adolescents particularly, can equitably participate in research. Yeah.
Thank you for that. While we were doing some preparation for this call, one of the things that came up is that working in this field, particularly around stigma, is not easy. And not just from a science viewpoint, the methodology, the instrumentation of stigma, measurement of stigma, and then what you do with it is not easy, which I think is an evolving topic. And we hope that our panelists today have contributed some of the thoughts behind how to approach it. Now, how to convert that into better instrumentation, better methods of study is an ongoing challenge that we'll all be facing. But I think a take-home message for me, and I'm hoping for everybody here, is something that came up from a panelist. A lot of this work requires true passion, engagement, and presence. This is a key part. We talk about unprecedented times. In these unprecedented times, it's our long-term partnerships that are key. For me, the resilience has been the wonderful people I interact with, not just the people in this panel, but colleagues from around the world. Listening to stories that they do, some of the amazing things they do, has been sort of feeding my soul. I hope it feeds your soul too. And so till next time, Shaili Prasad here, signing off. Bye.